Hello, I'm Dr. Douglas Ness here from Southern California in the San Diego area, National City, California. And we're going to be talking today, spending the next hour talking about endo. And I want to talk to you from a general dentist perspective. And so I titled my presentation, Easier, Better, Faster. And so many so many people I meet and talk to, other colleagues, they don't do endo, or they do very little endo because, either they didn't get good training, they felt, or they just never got the feel for endo. And so I want to try today to kind of drill down on a lot of my experiences. Now I'm kind of I used to be the young guy, now I'm the old guy, and or one of the older guys. And I have accumulated over 30 years of experience now. I can't believe that, but did endo all the way through that. And now we do a lot of endo. And I wanted to just share a few tips, I think, as we go through this presentation that hopefully will help you discern which cases you should pick and how you should go about it. And some of those things that you were probably taught years ago, but maybe have forgotten or just let them slip by. So today I want to kind of be, rather than say the academician with a lot of heavy, quotes from journals, we're not going to get this. I'm going to be more like a coach where I can maybe guide you into better technique or maybe help you facilitate that process of doing quality endo a little bit faster and more efficient, and which should be better for your patients and it'll be better for your bottom line. So everybody needs a coach here and there. Even Tiger Woods, Michael Jordan, they all have coaches. When people that perform at their peak level, they always have coaches. So hopefully I can share some of my humble experiences. A lot of times it's not because I invented some new technique, something new. It's because I found a pearl from somebody else, probably a specialist, an endodontist, and just took it for my own. So I'm a big believer in not reinventing the wheel, especially if that wheel's working great. So I will definitely adopt things, and that's kind of been, I think, very helpful in my career. And hopefully what I share with you today will help you along the way. So just a quick word, J. Morita Company has sponsored me. So I am disclosing that I have an honorarium from them, and they were kind enough to ask me to talk on this topic several months ago, and I appreciate this opportunity. Bear in mind that what I'm going to suggest to you is what I do every day and have done every day for many years, long before I developed a relationship with Morita. So what I'm suggesting is really from the heart, and it's something that I use every day. It's not a sales pitch, and I can just tell you what works in a general practice and can work very well. So just a little bit about me. Like I said, I've got a little bit more gray than I used to, but back in 32 years ago, graduated from Loma Linda University in Southern California. And then I went across the coast to Atlanta and back to Emory University, took my general practice residency there at the Atlanta VA Medical Center and Emory University. That was about a year or two after Emory closed, and they kept their specialty residencies for a few more years. So, but I had a great experience there. And it was actually there that in my general practice residency that I like to say it was the best thing that happened to me, and maybe the worst thing that happened to me, because it helped me really put dentistry together and put together the ability to develop the techniques and skills and knowledge to do complex treatment plans and refer less out. So I never did choose a specialty. I kind of stayed a general dentist and pursued a lot of education, a lot of continuing education. I think I'm over 3,000 hours now. I know it's a lot. I consistently did about 100 hours a year. One of my my proudest moments was getting diplomat status in the American Board of General Dentistry. Those of you that don't know it, if you're involved with the Academy of General Dentistry and fellowship and mastership, I would encourage you to look at the Board of General Dentistry. It's set up similar to the specialty boards, and it really is the highest level you can go in general dentistry and really challenge your skill set and your knowledge base. And I also got board certified in implantology with the American Board of Oral Implantology. And I've had a great time doing implants. But a little bit about my clinical background. After dental school, after residency, I went to Anchorage, Alaska, where I practiced for about 20 years. First, I joined a group of 6 general dentists. Well, actually, I was the 6th, I should say, and eventually became a partner in that group, and I stayed there for 9 years. And then I moved within the same city and did a solo practice where I more focused on more comprehensive prosthetics and implant dentistry. And then one of the best times of my life was recently in 2011. I had the opportunity to move to China, and I was able to be a comprehensive dentist, focusing mostly on implants, and I did orthodontics as well there in various cities in China, mostly in Shanghai and Beijing and Chengdu. I also had the opportunity to speak for Ultradent Company and some of their techniques and endodontic products, and in China, and that was a lot of fun. Got the opportunity to travel to a lot of cities and see how dentists practice and how things operate in another country. So that was eye-opening in a lot of ways, and that's another conversation for another time. But then I came back to the States and settled in Southern California again, which was where I grew up, but went a little further south down in San Diego. And now I own a group practice, a multi-specialty group practice, where we focus mostly, a large part of our practice is the Medicaid level of the society. And so we focus on specialty work, mostly oral surgery, endodontics, and prosthetics needs of the underserved, the lower class populations in San Diego County, of which there are a lot. San Diego County is one of the biggest counties in the country. And so we have patients from 100 miles away consistently that come, because most general dentists that take Medicaid, a lot of them don't get involved in the specialty areas. And in our county, the oral surgeons and the endodontists don't take Medicaid, and mostly because the fee structure is pretty low. So we've created this niche. But by doing so, in order to make it profitable and make it cost effective and just to make it work as a practice, we have to be super efficient. We have to be efficient with our time. Our procedures have to be, smooth and foolproof. And right now, I wrote there that we're doing about 150 root canals a month. Actually, I just looked at today, the last 90 days, we're up to about 200 a month. So we're going to do over 2,000 root canals this year in our practice, of which I'm probably doing a third of them personally. I have one other doctor, one of my good friend, Dr. Bastian, who does probably 3/4 of the root canals, and he's also a general dentist. And so we do a lot of different cases. We very rarely do we refer to the specialists, but for the most part, we refer retreats only. We pretty much do all the first-time endodontic procedures that are referred to us by other general clinics. And so that's a little bit about me. And just here, of course, those of you that haven't ever come to San Diego, I encourage you to do so. It is, we call it it's the greatest city on earth, and America's finest city, I think, is the nickname. And it's certainly earned that because of the weather. It is 72 and sunny every day here, virtually. And not too hot, not too cold. So it's what I like. It's a nice change. I spent 20 years in Alaska to get my fill of cold and dark and snow, and now I'm ready for the change, and I've been enjoying that. But I certainly would encourage anyone who has never had the opportunity to come to San Diego to spend some time with us. So what we're going to cover tonight briefly, And we're gonna hit them pretty fast, but I'm going to talk about who should be doing the root canals, a little bit about the endodontic distribution here. I'm going to talk a little bit about the minimum armamentarium that you should have, I feel, to do successful endo and efficient endo in 2021. Case selection, a big thing. The nice thing about being the general dentist is that you're the gatekeeper and you get to decide who does what case. You're in charge. So I want you to learn how to use that power to your advantage. Access preparation. Let's talk a little bit about access. That's the key really to doing smooth and quick endodontics. How to know where those canals are a little bit. We'll talk a little bit about that. Give you some key pointers as to when the canals may be a little calcified, they don't just stand out when you drop into a pulp chamber. How can you orient yourself? Just like we're all used to GPS, where are we? I'm going to give you a few little tips of landmarks and where to find where you should be drilling and removing dentin and where you should not be. I'm going to talk a little bit about my main device, the Indenting Handpiece, that I think will revolutionize what you're doing and why I think you need it. I think if you do endo at all and you don't have this handpiece, you're doing things too difficult. I can tell you that. Talk a little bit about filing systems. And then finally, a little bit of observation about what I think is the premier sealers right now, a technique, a very simple technique I use, which is a cold obturation, but it's a cone fit, a single cone fit technique with a bioceramic sealer. And I'll talk to you a little bit about the advantages of success and efficiency on that. And talk to you a little bit about, and we'll finish with the economic impact of single visit endo in your daily practice and how that can affect your bottom line. But who should be doing root canals? Specialist versus the generalist. Some of the research and prepping for this course, I found, there's about 15 million root canal procedures done annually every year. And 70% of those cases are treated by the GP. We only have, and thank God for all of them, about 4,400 endodontists in the US. So without the GP, there's no way they could do 15 million root canal procedures. They couldn't possibly, nor would they want to. They'd have to do over 300 cases a month individually. And I know endodontists like to work hard, but that would probably be too much. So we have a role. I mean, the general dentist has a role to have a good competency in a large percentage of root canals. So there's plenty of cases to go around, and there's enough for everybody. And so the key is picking which cases you should keep in-house, which cases you definitely should refer. And we'll talk about that in a little bit. But what I've always found, as I alluded to earlier, the best way to be successful quickly is to kind of copy what already exists around you. In any area where I wanted to expand, whether it was oral surgery or orthodontics, I always kind of looked at what the specialists were doing, especially when it came to scheduling and instrumentation and to learn their scheduling flow, how they schedule patients, and what systems they use to go through the entire appointment process. And I think that's very helpful. It's certainly, I'm analytical in that way, and I like to really get into those details. And I think that can help you if you sit down and think about what you're doing minute by minute in that root canal process. You'll find there's a lot of things you could improve on. But the GP is the dental healthcare system gatekeeper. You're the guy in charge. The most patients do not go to the endodontist first. They don't think of that for the root canal. They go through their primary care dentist. And so that's you. And so it's up to you to look at that case and go, if you do some endo, which cases should you do? Which ones maybe you should refer? You don't have to take on every case. The hard ones, and we'll try to give you some pointers on what's a hard one, what's could be an easier one in general. And by the way, your patient pays you the same fee, whether it's a hard one or an easier one. Your insurance company reimburses you the same, whether it's a hard one or an easier one. So you have a hard day anyway with all your other procedures, so you want to cherry pick. You really do. It's okay. And send the ones you really don't need to do, send them to your specialist. A little bit about armamentarium, I think, is imperative. You need you need the right instruments. And so for me, you need an array of burrs. You need an assortment of round burrs. You need surgical length burrs. You can't do endo with restorative length burrs because the restorative length burr is too short. It keeps the head of the handpiece in your field of view. You need that long surgical length burr to get that head of that handpiece away from the occlusal table of the tooth so that you can see down into the pulp chamber. And a lot of doctors are still, using restorative length burrs, and it just really doesn't work. It actually is going to lead you to some mishaps, perforations, over preparation, some mistakes. This is just a list, and for those of you, you can always go back and look at the replay, and you can freeze slides, and you can look at some of the things. This is just, I'd made a list of the things that I use, and just highlight a few things. We'll talk about Oroseal, which is a fantastic product. A mouth prop, some people don't. I mean, a patient is going to be there for 30, 40 minutes. You should try holding your mouth open for 30 or 40 minutes. It's not comfortable. And you really should have the patient still, especially if you're working on posterior teeth. The mouth prop can help position the patient and keep them in a consistent position so that you can move in and out of the tooth and not have to reset your eyes every time, and reposition the patient every time you're entering the canal and coming back out and in and out and in and out. You have to do that, countless times. So you really don't want your target moving all the time. So it's better if you can keep the patient as stationary and comfortable as possible. Let me go to, and another thing that we need, vision. Light and vision are key. So if you're my age, by now you need bifocals and whatnot. You really need loops. I mean, to do endo, you don't have to have a microscope to do a lot of endo to do it well. But I do believe you need magnification, at least 2.5, maybe 4.5. I have both, and depending on the case, I'll go back and forth. Most of them I'm comfortable doing with 2.5, believe it or not. You don't need a microscope, but if you have one, great, by all means. I wouldn't discourage it. Another thing about files, a lot of you just start at 10 files. A lot of canals are not going to cut it. You're going to bind and you're just going to sit there and grind and grind and grind, putting too much force in your files, and you never make progress when you should step down into a 6 or an 8. You need to start your files in your standard armamentarium at a 6, and you should have those all the time, always available. This is just my tray setup that we have ready for every patient. We have the files, the hand files, rotary files, irrigators with tips, with side port tips. That's what I knew I needed to mention something. Side port tips. You don't want the end port tips for your irrigants. You don't want the jet of liquid flushing straight down the canal against the apical frame. And it's a lot easier to have a bleach injury. And if you've ever had one with a patient, it's a great way to ruin your day, ruin your week. And the new side port needles are really helpful in being effective irrigators, but they're a lot safer. You need a straight Explorer. You need this D16 Explorer, and you definitely need that to find your canals and to move through the tooth. You need a straight line, not a curved Explorer. And mirrors. Most of us in restorative are using a number 4 or number 5. I would encourage you to use a number 3 head mirror for endo. You only need to see one tooth in endo. And it's going to be a lot easier to get back. And if you're working on first and second molars, it'll be a lot easier to keep the mirror in the right place if you use a smaller mirror. Your endodontists use even smaller mirrors. This is just a little display of my burr block, a variety of burrs for specific purpose. My high speeds, these are my 2 main ones, the 557 to open my initial access, the 4S to breach the roof of the pulp chamber and to remove the pulp chamber, the roof of the pulp chamber. On molars, on bicuspids and anterior teeth, I'll probably switch down to a 2S and a high speed to do that same procedure. And then I have a fine diamond, rounded diamond that I use for flaring and smoothing and removing overhangs of the pulp chamber roof. And you need something like that. Once in a while, this is a quarter round burr that is very handy if you use it. If you have an electric motor, then you can turn the speed down and maybe go around 20,000 RPM. You can use that to open up the commonly there's an isthmus of pulp tissue between, say, your lower molar, mesiobuccal, mesiolingual canals, and you can cut that groove out and grind that pulp tissue out and clean that area out easily. Also, it's good for caries removal and also working slowly, a set of slow speeds if you're trying to search for a canal orifice. A variety of long shank or the surgical length slow speeds are very helpful. I also have some kind of occlusal reduction burr. I use this football. I actually use a green coarse grit now, but this was an older setup and so forth. So you need a good array. Perfect isolation is imperative. And one thing I found is the rubber dam clamp and the rubber dam is not perfect. There's no matter how well fitting it is, it can still leak around the neck. And all it takes is one drop of bleach to get past the rubber dam, and your patient starts coughing and gagging, and it just ruins that whole appointment. So I found this product from Ultradent, Oroseal caulking. It's a putty-like syringeable material. It's a food starch-based product, and it just finishes that seal. When it's wet, it stays stuck to everything. It's easy to rinse off, though, and I use this every patient to complete the seal of the rubber dam. Case selection. This is a big part of the appointment of our time today. Cherry pick, as I said, which ones to keep, which ones to refer. So this list is just a quick list of what I think, say a general dentist that does, here and there a root canal, one or two a day maybe, or one or two a week, but wants to grow and wants to increase. I'd say you got to crawl before you can walk. So let's keep it simple and keep you successful. So I would say keep the teeth young, somewhere between 10 and 50 years old. You don't want to go too young where the apices aren't formed, and not too old where they get calcified. Upper anteriors, okay, bicuspids, canines, as long as you have 31 millimeter files, and first molars that have fairly straight canals. And this is just some of the examples I can show you. You've got fairly straight canals. You can see the canal to the apex, from the coronal to the apical region. The canals are just gently curved, not too curved, and try to keep things like that. This is another example here. Here's another example. Anterior tooth, again, well-defined pulp chamber, but you can see no matter what, we can get off track. We can see my axis. I actually went a little bit off course. Even if I think I had my burr parallel to the long axis of the tooth, my axis, I was a little bit off. And fortunately, I caught this pulp horn and started seeing some bleeding and was able to unroof the chamber and go to the distal and straighten my axis out. But lateral incisors can be a little tricky because there's not a lot of material there. You can't err very much. But you can do these cases very efficiently, very rapidly if you choose cases with younger teeth, open canals, and then you can finish these cases in minutes with the right setup. And this case was about, I think, it was about 25 minutes in the mouth. And you can do that consistently. Again, we've got open canals where a 10 file will go to length very easily and very rapidly for you. And then you can get to your rotary instrumentation very quickly. Which cases did you refer out? Number one, cases with crowns. Don't do cases with crowns. Upper second molars, stay away from those. They're just hard to access. Why should we? No crowns? Because you can't see the pulp chamber. You lose your orientation. You can't, actually the teeth aren't, because the teeth aren't necessarily in the same orientation. You don't know if that tooth was a little bit rotated and then the tooth is prepared and then the crown is made straight. it's always altered. You also take a lot more time to cut through the access. So give those to the endodontist. Any teeth in patients that are over 60 years old where you can't see the canal all the way to the apex, I mean, you don't need those. Get rid of those. 90-degree curve roots, young teeth without closed apices. Do you want to deal with apexification procedures and have the patient back in 6 months and all that? Pulp stones. Older teeth are going to have pulp stones. And you might think you're in the pulp chamber and you're just at the top of the pulp stone and you still have a ways to go. Again, more difficult. Give them to your friendly endodontist. Here's some examples here. Look at this one. Oh, this looks good, except is this the end of the root? No, not so fast. The canal fades out, but actually it goes over here. It takes a nice dog leg to the mesial, but you can't even see the canal here. This one, I would probably send it off. This lateral incisor. Can you be sure where the long axis and where the canal is? I don't know. Severely curved roots, a second molar, tough access. It's tilted distally down the throat. You're going to have a hard time getting access. It's just a lot of work. I don't know that you want to deal with it. Same thing over here. Second molars, just send them off. There's plenty of teeth for you to do without that. Through crowns. Look at this bridge retainer. Can you see the canals? I can't see them. Also, where's the long axis of the tooth? The crown has been changed, right? If you dropped in like you think through the occlusal, you might totally miss the pulp chamber over here, and you might actually perforate out the side of the root. Your trajectory of your palatal canal will take you right here. Your axis should be actually on the mesial marginal ridge. Same thing here. This one's tip mesial. Can you be cognizant of where a straight line access is? Plus, you have to cut through metal. Is this base metal? You're going to spend a lot of time with this. So I would recommend getting rid of it. This one too, I can't even see the pulp chamber or the canals. This is one for the endodontist. Don't even touch these. Just send them. You need straight line access. And that is the key to speed. We're all in awe when we see endodontists in their seminars make these teeny weeny little access preparations, even in molars, and we all get discouraged that we can't do that. Well, you don't need to do that. Okay, if your tooth is going to be restored with a crown, it's not so critical. A lot of those cases already have crowns on them. They're trying to preserve that restorative material, and they're going to take that time. But if you're treating cases that are mostly natural teeth that have been destroyed by caries, your accesses can be bigger. So get the tooth out of the way so you can get into the pulp chamber. It's going to decrease the stress in your fingers and your hand and the rotary files. Another tip, things that I've learned along the way, assume all molars have 4 canals until you prove otherwise. Look for that MB2 until you search and search and search and you're absolutely satisfied. Look for a distal lingual canal and lower molars. We're consistently now seeing cases with 5 canals. We're seeing lower molars. My partner, Dr. Bastian, last week just did an upper molar that had MB2 and DB2. You can get all kinds of crazy cases, but molars, more than half of the time, have four canals. So assume they do until you prove otherwise. Another thing, the canal orifices are directly under the pulp horns, which are directly under the cusp tip in the bicuspids and most teeth. In the mesial buccal of your upper molar, it's right under the cusp tip. That's where you should be looking. You shouldn't be, if you can't find the canal, check where you are. Bring your vision out to the occlusal table and use your straight explorer and try to draw a straight line under that cusp tip down to the pulpal floor. And that's where you should be grinding, denting away, not anywhere else. Another tip, you want easier access, do your occlusal reduction for your crown now at the endodontic procedure if you're doing the crown. Especially the mesiobuccal cusp of your upper and lower first molars. Those are usually the toughest canals to get into. You usually have to tip your handpiece and your files really a long way to the distal to thread the tip of your file in. So if you make it a lot easier if you remove that mesiobuccal cusp. tip number 5. The canal orifices are at the junction of a pulpal floor and the axial wall. So I kind of think of it as if your pulp chamber is a room, like the room I'm sitting in, a bedroom. Your canal orifices are going to be in the corners. If you stood in the corner and you had 2 walls on each side and then the floor, you should be able to find that canal orifice right below where you're standing. And that's exactly where they're always going to be. The other thing is you'll start to know, if you start to look closely, you'll notice a different coloration of the pulpal floor dentin and the axial wall dentin. And the axial wall dentin's a little lighter, a little yellower, little lighter in tone, and the pulpal floor dentin is a little darker. And where those shades merge is generally also that junction where you're going to find that canal orifice. For your accesses, again, some of the tips, you can kind of divide the tooth into thirds for your incisors, both mesial-distally and occlusally, and that's where your entrance point would be. That's a typical tip for your incisors. But again, your pulp horns and your cuss tips, that's where you're going to find the canals, right below them. They're going to be sitting right below them, right in line. So if you always keep aware of where the cuss tip, right here on this bicuspid, cuss tip, right directly below there is where's your orifices. And that's where you should be looking. Not over here, not over here. You got to be really careful and stay in your center line, but always be cognizant of where the cuss tips are, especially in worn teeth. You have to be even more aware. Where you kind of imagine where that cuss tip used to be. That's where below that is where you should be looking. In molars, I found these diagrams. I don't really like this upper molar diagram. It's really a little bit off. This palatal root, really you're going to find it more over here. And if you take a straight line between the mesiobuccal canal and the palatal canal, generally that imaginary line you draw with your mind is going to be pretty parallel to the mesial marginal ridge and the mesial wall of the tooth. That's generally where you're going to find, if in a straight line, you're going to find that palatal canal or your mesiobuccal. Usually I find the palatal canal first. It's usually the one that's the least chance of being calcified. You usually find that, and then start moving buccally until you can find that, the mesiobuccal. And then the distal buccal is somewhere over to the distal. On the lowers, something you want to keep in mind, if you have a single distal canal, follow the center line mesially right to the center, and then go out buccal and lingually. You can find your canals usually. Sometimes if you see one canal orifice in the center line on the mesial, it doesn't mean there's 2 canals only. A lot of times the 2 canals, mesiobuccal, mesiolingual, are so close together, at first glance, it looks like it's 1 canal orifice. But when you open it up, you'll find 2 tiny little orifices that tend to tilt lingually and buccally. So be careful of those. Automation is what we need now. We're always looking at automation. Those of you that drive Teslas with autopilots, of course, you still need to drive it. You still need there's still a certain amount of manual control you need. So but with computerization, it really helps us do things better. It can help us drive better. It can help us get to our destinations better and more precisely. Like your Tesla has a GPS that'll get you within a few feet of your destination. And then it has, of course, those sensors around the perimeter that'll get you within a few inches of wherever you're exactly trying to park, whatever space, and get you centered in that space so that you don't have a collision. So it has different levels of computerization that can help you operate your vehicle. Well, we have that in endodontics too. We have machinery now that can help us reshape the tooth and clean the tooth, can also tell us where we are constantly inside that canal. And that's really what we'll talk about a few minutes here now. Some things that we like to see with an efficient cleaning and shaping system or instrument. We want to have electronic apex location. We want to have a compact handpiece that's easy to hold, easy to manipulate, cordless would be preferable. We'd like it to spin our rotary files, or reciprocating files would also be sensitive to not over torquing, so that we can minimize file separation. And ideally, if we had a system that would work simultaneously with electronic apex location, so when you approach the apex, the file would stop or reverse. That would be the optimal system, so that you wouldn't over instrument and you wouldn't file outside the apex. And we want a system that's compatible with your favorite file system. Just a little bibliography on apex locators work. There's a lot of documentation over the last decade or more that show that apex locators of all sorts are effective and accurate, and actually are more accurate than digital radiographs in determining where the apex are. And that's pretty universal. You can look some of these articles up on your time. This one found that apex locators were superior to radiography, and there's no question. I use them both. I use radiographs simultaneously, but I have done many root canals where I only take a final X-ray. I'm so confident of simultaneous apex location with instrumentation that I can do that. And as if you get this instrument and use it, you'll do the same thing over time. The instrument, my favorite one I've been using since 2017 when it came out, is the Morita Triauto ZX handheld device. It does all these things that we talked about. It has all the attributes of kind of the ideal endodontic automated instrument, and it's easy to hold. One thing I like, it has your readout right where you can see it very easily. It also has audible tones, but the neck of the handpiece, it rotates 270 degrees, so you can position the battery pack, main part of the handpiece in your palm of your hand and rotate the head of the handpiece to enter the tooth, so that you can see the screen at all times. And so it's nice to be able to simultaneously read the screen and also be able to see where your handpiece is. And that comes very handy. It has different settings. It has different modes. It has just apex location. It has this is filing, just say you're opening the canal. It has a system called OGP, which is called optimal glide path. And that's kind of a reciprocating motion. It emulates your hand motion of the watch winding or the balance force technique, where you're going 180 degrees back and forth, but it does it at 300 cycles a minute, so much faster than you can. And you can actually use special files to negotiate your canal and do this fully automated without hand files if you choose. It also has optimum torque reversal, the OTR, which is what we use for a cleaning and shaping mode. It you set it to your file specifications. You can set the torque and it will auto reverse when it gets close to exceeding that torque. It'll stop. You can set it to stop or auto reverse and relieve the stress of the cutting fluids of the file, and then it'll resume and it'll kind of go back and forth like that until you remove the handpiece out of the canal and clean the flutes of the file. So it will prevent you from over torquing. That doesn't mean that you can't manhandle it and break a file, but we'll show you a little bit here. And this is showing the OGP technique, or the OGP mode, which simulates your hand filing. And so you can see how it goes back and forth. And you just use a pecking motion and just tap, tap, tap. You want to use it very light pressure, pretty much just the weight of the handpiece. You're not pushing, and you're just pecking and gradually going down the canal. And just a little bit here. I'll show you this one. This is the clean and shaping mode, or the OTR. And this is basically just a demonstration of how this instrument works. And so when you load up the files, it's going to stop. If you get close to the torque setting, it'll stop and it'll reverse and release the stress on the file, release the bind. And you can, and then it'll back, and then you can remove it, and then you can clean the flutes and irrigate, re-enter, and so forth. This video will just quickly show you is how you would use this in a real tooth, although this is a mounted tooth, so it just takes a couple of minutes to show. And just for a quick demo. And they picked a pretty easy tooth, but here you can take your, this is going to use the Pro Taper system with the SX or the opener file. This is pretty much what I use. And just flare your coronal section. Then they're going to find the glide path. Instead of a hand file, they're going to use this reciprocating OGP program at 300 revolutions a minute. And it goes 180 degrees back and forth. And then just, you saw that rapidly, it reached the apex in just seconds. Then you'll switch to your cleaning and shaping files. And you'll go to setting number 4. And this is where it's the OTR, the optimal torque reversal. And so if you exceed the torque, it'll reverse. And now we can flare and find our final apical size in this case. Filing systems, it doesn't matter so much. Some of you like reciprocating. I'm a fan of rotary. I'm a fan of a simple, I use the Pro Taper system, been around a long time, variable taper system. It works well for me, but I wouldn't fault any of the modern systems. If you have success with it, you can have even better success with this handpiece, I think, because it is always telling you where the apex is. And you can run up to the apex and have a superb control within, a couple tenths of a millimeter. And you can clean and shape in just minutes, really less than a minute on a lot of canals. And so it'll work. You can use the OGP setting with a reciprocating file system, or then you could use the OTR for your rotary file system. Some of the things that I use to finish in shaping, and I use a matched system. I use the Pro Taper's matched cones, so I tend to have a single cone fit. They also have matching paper points, so really 1 or 2 paper points and the canal is dry, and then I'll go to a sealer. I'm using currently Septodon's BioRoot RCS. Has a lot of good research behind it. It's very biocompatible. One of the more most of the research shows it's usually the most biocompatible next to osteoblasts. And our experience over the last 2 years, we just pretty much have, I would say, less than 0.5% complication rate where we have post-op pain, or where we feel like we have to re-enter a canal, and that's over 1,500 root canals a year plus. Interesting, this study here, the last statement of the abstract was very interesting. It compared your old AH plus pulp canal sealer to BioRoot RCS, and it shows that there was no biocompatibility on those other older sealers, but the BioRoot RCS had positive influence on the cell metabolism. It was actually bioactive and it was biocompatible. It actually encouraged osseous repair, and that's kind of what we're seeing. We're really sold on that product, and really feel like it's another key to our success. Just a little bit reference, you can look at this bibliography on the BioRoot RCS. Just real quickly, this is just a case I pulled out real quick, just showing you this bicuspid we did. Just real quick. Access, what it should look like under the cusp tips. This is where we're looking for those canals. Have a nice expanding access where it's straight line. You can see the canals very easily. You can enter the canal. Here we've opened the canal with the SX file. This was tight, so a 10 file didn't go to place, so I went back down to the 8. You need to have those 6 and 8 files handy, and then your 10 file to just get canal patency, and then go through. This is the finished rotary after rotary instrumentation with the Triado ZX. Then canal fit, single cone, pro taper cones, and then our finish. And this case was really a 15-minute case, start to finish. And if you pick your cases, I mean, you can do this. The bottom line, what would it mean, if you, to your practice, if you could do an extra molar endo per day in an hour or less? And then when I say an hour, that's an hour appointment time. That includes setup and cleaning the chair. So your surgery time or your operative time, is maybe 40 minutes. So what would that mean to you? If you added another $600 to $1,000 and it only costs you about $20 in supplies, your initial investment to get some of the instruments I've shown you, and even including the Triado ZX, is probably $2,500. That could add you over $100,000 in gross profit in your production per year. So I think it's something to consider. But again, the key is picking those cases. And again, cherry pick those cases. Pick the easiest ones. You don't be a hero. You don't need to. There's so much endo out there to do. You need to be a hero to your patients and do it well and do it fast. So I think we're right about time, maybe a couple minutes over. So hopefully we have some questions. And I'm going to go to the Q&A here. Oh, here it is. Okay, Zoom user, any good tip for a calcified canal? Okay, so you definitely want to have EDTA early on. The best tip for a calcified canal is to not do it and to refer to your endodontist. It's the best tip I could tell you. But if you're going to tackle this, EDTA and walk away. Go see another patient. Honestly, fill the chamber, let it sit for 10 or 20 minutes. I mean, a while. The biggest thing about, and it will help you. If you feel like you're close to the canal orifice, you're pretty well. The other thing you need to know is you need to be willing to take a lot of progress x-rays, meaning you're only removing, if you're searching for a calcified canal, you're only removing maybe a 0.5 millimeter of dentin, and then you're going to take another check film. And if you're willing to do that, go back and forth to be safe, because it's very easy to get off track. Again, you need to know where to orient yourself in that pulp chamber. Where are you looking in the right place? If you have a CT scan, taking a cone beam and an endo setting can be really helpful to have that. I've done that. I've closed it up with an EDTA pellet, have the patient reschedule and come back. But on the way out the door, I take an endo CT, so I have it back the next time. So those are some tips. Have sharp explorers. Have a really heavy, a nice sharp, that D16, I guess the number is. I'm not 100% sure, but that straight explorer. Because the dentin that's calcifying the canal is a little bit softer. It'll usually compress, and you usually stick it when you hit it. And so those are some of the tips. Usually those help. Have yourself, if you can invest in a piezo scaler with some endo tips if you want to get more advanced. I don't know how advanced or how much you want to tackle it, but you can go into there. Now we're getting into the specialist territory, so I hope that helped. Does the new Morita handpiece have a separate reading display, or is it just the handpiece that is read? Oh, no, the display is on the handpiece. So this is a different device. This is a handheld cordless. So everything you need to know with that instrument and control it is right in that handpiece. And if you go to their website, they've got some great pictures and videos and things like that. Can we still use a discrete apex locator for anything, or do you think they're obsolete? Honestly, I don't, because the apex locator is integrated into the Triado ZX. That's all I use now. I do have an apex locator somewhere in my closet. I suppose if my Triado ZX broke and I had to send it in for service, and I wasn't going to buy another one, I might pull out that apex locator. But there's not much use for it, because this does everything that apex locator does, because it has it has a cord with the ground for the lip, and it also has a clip, so you can use it. That's what setting number 1 is. You set the handpiece on my bracket table, and I look at the display right there. So use one instrument. What kind of sealer to use, and does it not need heating? My sealer, I use the BioRoot RCS, as I said, from Septidont. That's a powder liquid. You mix it just like any cement, and I lay it in with setting number 8 on the handpiece is a reverse mode. And so I usually go down 1 or 2 size of my rotary file smaller, and I use that to apply the sealer, and I will just stroke that in the canal walls. If you want to dip your canal, before that I was just painting the walls with the gutta percha point a few times before I finally seeded the gutta percha point. But what I use is a cold sealing, so I don't use warm gutta percha. I use 1 cone fit. It fits like lock and key into the canal because I've machined the canals the exact size of the gutta percha point. So all you have is a thin film of sealer that is being compressed by that gutta percha. Let's see, do we have any? Oh, here's some more. Yes, I use EDTA at the end. So yeah, I had to rush through it. I apologize. There's so much material but I use EDTA. I'm not sure what brand I'm using right now, but I use that after my bleach, after I've digested the tissue, after I've cleaned and shaped, and my final rinse will be EDTA, and I leave it in for about 20 seconds to remove the smear layer. Think of EDTA like your bonding primer, and you're trying to open those tubules. What do I use to seal orifices? I think you mean maybe my access. I use pretty much Cavit. If I know I'm going to be restoring it in a few weeks, I'm just going to use cotton and Cavit. If the patient is asked to go longer, I may use something like the old eugenol IRM, or maybe a glass ionomer, something with a better seal, because Cavit degrades probably in 4 to 6 weeks. So I always I'm always very insistent and beat into my patient's head that we're not done, because I'm acting as a specialist a lot of times where the restorative dentist is going to take the restorative phase, do the crown. I really have to hammer home that they need to, as soon as they leave my office, call that dentist to get in their schedule. Any tips for retreats dissolving gutta percha? Yes, chloroform still is what works. So you can get that from your compounding pharmacy, or maybe Henry Schein. You can get it. I can't remember. We use so little of it, and the bottle lasts for so long. But chloroform really works in dissolving gutta percha. Just a few seconds. I put it in the same 3 cc syringe with one of my side port needles, and just a few drops in there. And I also, Dentsply makes a retreatment file for your rotary handpiece. It's a little stiffer, and it works wonderful for removing the bulk of your gutta percha out of your canal. That you can find on Dentsply Sirona's site. I can't remember the name of it, but you can find it if you look around put retreatment in your search. Irrigants recommended. Well, you need irrigants. So you need an irrigant that digests tissue. You need one that disinfects. You need one that removes a smear layer. And you can't do all 3 things with one liquid. So bleach, either full strength. I use full strength, but some doctors cut it in half, use 2.5%, but I use regular Clorox bleach. And then I use EDTA. Some people rinse at the end with chlorhexidine, which you could do. I'm not currently doing it, but there's certainly some benefit. That's a whole other lecture on irrigants, so that's about all I can say on that topic. What burr do you suggest for getting to a pulp chamber that is narrow, occlusal, gingivally, while making sure that you don't perforate? Well, again, I probably ran way too fast on that, but I use the 557, my operative burr, just until I feel I punch through the roof of the pulp chamber, but then I don't do much more than that. So I just basically create a pulp exposure. Then I'm going to use my 4S high speed. I'm going to switch to the 4S high speed. And I'm going to use that where I'm going to drop into the pulp chamber and I'm going to pull out. I'm going to have the power on and I'm going to cut the roof. I'm going to be lifting it away from the pulpal floor. My pressure stroke is lifting toward the occlusal, and I'm cutting back the roof of the chamber and exposing and opening that pulp ceiling. This is hard to do in words, but basically, yeah. So you're not going to perforate if you won't perforate if your burr's never on the pulpal floor, and so it shouldn't be too much. The other thing they make for cutting the axial wall, that red diamond I have, and you guys, if you go through the replay, you can see, you can stop, I think, pause and see some of the pictures. But that tapered basically is a crown and bridge diamond. I use the old ones where the tip is kind of worn off. So you can kind of wear the diamond off the tip and make it safe-ended. Some companies, I think Dentsply makes one that makes safe-ended tips. You pay a lot more money for them, but you can make one on your own by just dulling the tip. What situation would you medicate with calcium hydroxide and get the patient back for a second appointment to finish? Okay, yeah, virtually all of our appointments are one shot. Even with an abscess tooth, I'm going to do it in one shot if I can get dryness. If I can get my paper points, I can get totally dry in every canal, I will obturate that day. If I cannot, if I'm still getting some suppuration, I have a big lesion and it's weeping, then I will dry it as best I can and then fill it with intracanal calcium hydroxide. I'll do all my cleaning and shaping so that all my work's done. I've created my apical stop. Everything's good, but it's still weeping. So I'm going to fill with calcium hydroxide, have them come back in a few weeks, and then I will just quickly rinse out and use my final shaping file, clean the canal wall as well, get rid of all that, and then finish my obturation. My last irrigant is EDTA for me. Then a water rinse. I rinse the EDTA out with water. So I guess technically my last irrigant is water. Most of my endos are separate procedures, so I do not place the post the same day. Also, if you do it, you run the risk of dislodging your gutta percha a lot. The sealer needs time to set. And unless you use some of these dual cure resin sealers like EndoRes from Ultradent, where you could light cure and set it, you're running the risk. I mean, you got to be judicious with, using your pluggers and heating down, going down the canal with a hot plugger as far as you can before you use a rotary, your piezo or your drill burr. Let's see, what is your irrigation time? What are your thoughts regarding warm obturation with oven? You're probably talking about thermofill, which I used to use thermofill probably when it first came out, early 90s, probably for 10 years. Had great success with it. The problem is making post space and retreatments. The plastic core is really kind of a bugger to cut down. And I just kind of fell out of favor with it. It's expensive too per canal. My cones cost like 15 cents a piece. I mean, so even the machined ones, the branded ones from Dentsply, I mean, they're pretty cheap. So, I think 60, I don't know what the math is, 60, it's about $20, and maybe they're 30 cents a piece, $20, and there's like 60 cones in the box. So pretty cheap. And thermofill, I think you're $3 to $5 an obturator, or they're not cheap. So with me, our reimbursement for our molars is like $500. So I have to be smart. Do you do 2-point root canal? Has ever decided? Okay, I think I answered a similar question. So I'll go on to the next one. What anesthetic do I typically use? I pretty much always use 4% articaine from Septidot. That's my go-to drug. I think it just plain works more consistently, especially in what we call hot teeth. What endo system do you think is good for thin canals like MB2? Well, you need number 6 files. Okay, you need you need good loops. That's it. The endo system you need is good lining, good loops, and number 6, 8 files, and then this instrument with the steel files, which I didn't talk about, from Mani Dental from Japan. You can get them from Pearson Dental Supply, I've found, and those steel files that go in the handpiece for the Ogp program that mimics your hand motion, those things like that will help you with MB2s. And I think I hit them all. So, and we're at 4:59. So I stayed on time, and I want to thank everybody out there that came to this seminar today. I hope I've been helpful. I just kind of shared the last decade of what I've learned by the easy way and the hard way, and hopefully passed on some of the pearls to you. And hopefully you can take some of these and use them. And I would encourage you all to look at the handpiece. If you already have a torque sensing handpiece, fantastic. But you should have a look at this integration of the electronic apex location. Yeah, I think it's revolutionary, and I don't think there's anything else on the market like it. And it's been about 4 years now, and I don't see anybody else with anything like it. And Morita is really state of the art in this area. So, that's my shameless plug for Morita, but so be it. I'm a satisfied customer. In fact, when I first got it in 2017, I used it for about a month, and we had 2 other doctors doing endo, and I couldn't find it all the time. So within a month, I bought a second one. So that should tell you something about how we like it. So anyway, thank you all, and take care.